Thank you, everyone, and thank you for Samuel for having me back again. I can understand that all of you are a little bit anxious as we start this journey. It can be a very scary process, but I would ask that you, like any adventure, if you engage, if you do your homework, then it becomes less anxiety-provoking, and this is really not as difficult a path as one may imagine. We are located near Los Angeles. We strive to be more of a boutique practice. It's just myself, and we have approximately 30 employees now. And our goal is to offer individualized, compassionate care. So, is this the clicker? If you guys have any questions, you can find me afterwards. What I'm going to do is talk about egg donors and things to consider. So the first is, when do we switch over from our own cycles to a potential egg donor? And I think this is a very important consideration when we think about surrogacy as well. So the criteria that I use is what's medically appropriate, emotionally appropriate, and financially appropriate, because I think you have to incorporate all three of those factors into your decision-making process. Because anytime we think in a vacuum, when we don't consider, let's say, the financial factors or the emotional factors, then we're really not providing the best advice that we can. So medically speaking, unfortunately, donor eggs are mostly going to do better with your own eggs, especially if you've gone through multiple failed cycles. But I think this is where you really have to look at, why did the cycles fail, and then decide, is it worthwhile going down the path of a donor, and also honestly looking at the chances of success. I'm sure everybody here has heard of people that have failed multiple IVF cycles and then have conceived on their own. And what this details is that fertility is a chance of success, and the odds that are favorable for one person may not be acceptable for another person. So we do have to look at that option. And this is a young lady who went through 3 cycles of IVF before she came to me. And we looked at the treatment protocols, and we thought that they were not appropriate. We changed things around, and this was the first cycle, and it resulted in her daughter. But it's very different from what I'm about to present to you next. Well, let's talk about the emotional aspects. And I think these are just as important as the medical aspects, because at the end of the day, when we do have the family that we want to be able to look back and say it happened in the right way for us. And this young lady, actually she's 50 years old, she just delivered twins, 2 girls, and it was her 6th transfer. And the question was, when do you give up? When do you continue trying? And it was a story of perseverance that led to this success. It was a lot of inner strength and the clinic and her coming together and just deciding that this is important enough that we're going to make this a successful experience. And so I don't think that there's a hard and fast rule as to when to give up. I do think it's good to be open and honest and understand that this can be a difficult path, and sometimes it just requires perseverance. The financial aspects. Quite often when we're doing our own cycles, especially in Australia, they may be covered through the National Health Service, whereas if you switch over to donor cycles, it will not be covered. But more often than not, one donor cycle will result in many, many embryos, more than enough to complete the size family you'd possibly want. Whereas going through your own, especially if you're going through multiple cycles, then we'd be lucky to get 1 or 2 usable embryos. So how do you choose, or what characteristics to choose, and why? And I think this is about teamwork, because what happens is that as a patient, you're going to look at the characteristics in the donor. Is height, weight, eye color, hair color, is she artistic, athletic, all of those factors that might be important to you. And I think quite often we want to be able to create a bond with the donor, even if we know her, we don't know her. Either way, there needs to be a connection. And that's something that we as a physician has to respect for you as a patient, that we're going to, whatever you desire, we don't judge, we just want you to make the right decision. But along with that, we have to, let me go back here. We have to go back in and look at their reproductive potential. So I'll get to that. But in terms of the characteristics, a lot of what I see is people saying, well, she has great musical talent. I love music. I want to choose this donor. Or, this is the look I'm looking for, etc. And so what my staff and I, who've gone through hundreds and hundreds of these every year, we went back and came up with a little quiz for you guys, just to look at, see how good we are at predicting which baby came from which donor. So this is a young lady that was born, and donor A on the left, donor B on the right. You guys can think in your own mind. It was donor A. That's right. So let's go on to the next one. This is a Christmas card that we got. Beautiful young lady. Donor A, donor B. Here's B. Good job, guys. Okay, how about this little guy? He just turned, this was for just a month ago. See, donor A or B? It's B. And one last one. These are twins, born to a couple in the Carolinas. A or B? B. See? It's not that easy, right? So, but again, now this is what the physician's responsibility is, the reproductive potential. Because you might have found the most perfect donor in the world. I had a patient from Brazil. She was an OBGYN. She'd gone through multiple failed cycles on her own, had gone through a failed donor cycle there, and she found a donor, I forgot where it was, in Eastern Europe, PhD student. She said it looked exactly like her, was very, very happy. Unfortunately, when we checked her AMH, it was around 1, and I said, we can try it, but it's not a good decision. I definitely would not recommend it. She became very upset at me. Over the course of 2 or 3 months, her anger kind of subsided, and we talked again, and she understood that by the time people come to me, they're not just wanting a chance at success, they pretty much want guaranteed success. And being put in that spot, having that pressure on me, what I want to do is be able to give you appropriate feedback and say, hey, this is the right donor to go for, where we will have multiple embryos that are left over. You can have any size family you want, versus we have 1 or 2 embryos and we are very deeply anxious that are we putting them back in the right situation or not. So the way I decide, I look at the age, because age does determine quality, but my cutoff is at 27. Sometimes I'll stretch it to 30. AMH, I like it to be greater than 3 nanograms per ml. Just remember that the units that we use in Australia are different, and the conversion factor is approximately 7. Look at the antral follicle count. I'd want that to be over 20. And prior cycles. I think if we are choosing a known donor, to be able to go back and review the prior cycles is incredibly important. Okay. How do the numbers change over time or over a cycle? So what we have is a number of eggs, and whatever number of eggs we get, approximately 80% will be mature, 80% of those will fertilize, 60% will become blastocyst, and then 75% will become normal on PGS testing. And that is a number that is different for each clinic, and that's one way to assess basically a clinic's IVF laboratory, because the percentage of normal embryos in a donor cycle is basically a control that one can use and can compare clinic to clinic. Okay, so this is a young lady who whose background is Chinese and Scottish, so very unique. And she fit the profile of an intended parent perfectly, and we were able to use her. And unfortunately, she did not have a high antral follicle count, and she did not have a high AMH. But because she was unique in her ethnicity, they wanted to use her anyways. We did get 10 eggs, and we had 5 embryos. And remember that both the sperm is important as well, but mostly it's the egg that determines the embryo quality. And about 99% of my patients choose to do PGS testing. These are the results from her embryos, and the intended patient is pregnant, but you can see that only 2 out of the 5 embryos were normal. And on the left, where it says embryo grading, not all the higher graded embryos were normal. So personally, I do recommend PGS testing, even in a donor cycle. Because let's say you go through and you put in 2 embryos, 1 embryo 1 month and 1 embryo the next month, you don't have success. then you're back to zero. You don't know if it was the embryo or was it the uterus. If you've done the testing, then you can be a little bit more confident that at least it wasn't the embryo and that perhaps we need to consider using a different uterus. So that's where I think that, again, being kind of the person of last resort, it really helps in planning to be able to have this kind of data beforehand. Okay. And this is another donor. Now, obviously, she has a drink in her hand, which a lot of my intended parents don't like. But she is going to med school at UCLA, so that's a lot of characteristics people do want. And we did a cycle with her recently, and we actually were able to split it between multiple couples. And what I have are results from 2. So this is just off of 1 cycle. So this is, you can see we had 6 embryos, and all of them tested normal. There's a picture of the embryos on the right, the ones that we transferred. And this is the other set that we've used so far, and you can see 5 out of 6 tested normal. That's phenomenal. So we have 11 out of 12 embryos that tested normal. And these were where we gave each 6 eggs. So we have 6 eggs, all of them fertilized, all of them made it to blastocyst, and you have 11 out of 12 that are normal. That's a phenomenal donor that time over time will do well. So those are the kind of things that you want to consider and you want to look for, especially where we have a situation we want to switch, we want to split the eggs between 2 individuals. So let's say we have a male-male couple. We want to be able to use 1 donor, 1 cycle, have a good number of embryos to deal with, be able to decide if one person wants a male or a female, have all of those options available to you. And if we make the right decision going into the process, then we can have all of those options available rather than being in a panic that we only have 1 or 2 embryos. They may not be the gender that we want, or the quality may not be what we're looking for. Okay. Finally, we just had a photo shoot with the little babies, and they're always cute. So anyways, that's my talk. Any questions or concerns? Anything?
So anyone have any questions? Yes, we do have one down the front, Dr. Kumar. Karen, there's a microphone.
Hi. The 50-year-old woman that you were talking about that did her 6th transfer and then delivered twins, were they with her own eggs or were they with donors?
Definitely not with her own eggs.
Yeah, that's what I thought.
No. No, it was the first couple of cycles she did. She was 45, and they were with her own eggs, but they were all obviously not genetically viable. Okay, she has a very high AMH. With a very small amount of drug, she makes an incredible number of eggs, but unfortunately, the viability is not there. That was more a story of perseverance, emotional perseverance. I think that when I think about egg donors or surrogacy, when do you make the change? I think a lot of it is not the simple decision as to when it's medically appropriate to make the change, but when is it also emotionally appropriate? And to be able to, for a patient and physician to connect and say, go down that path together, I think is incredibly important. There's no way she could have afforded surrogacy. And for us to try different manipulations, to be able to have that success, was a life-changing experience for her.
Thank you, Dr. Kumar, for a very interesting presentation. And